Andrew, you've shared so much with us about rapamycin. What other drugs are currently on the market that can either be repurposed, or are there any other clinical trials happening for longevity at the moment?
So frustratingly, there aren't any clinical trials currently happening for longevity itself. There are lots of drugs that might be able to slow down the aging process, but the way that this normally works is that there are trials for specific diseases where we know that that particular aspect of aging is a problem. So I think we'll talk later about senolytics, which are these drugs that kill aged cells in our bodies. But currently, all the senolytics trials are for specific diseases where these senescent cells appear to be an issue. And that's because it's just very hard to do a clinical trial for aging. You have to get a very large number of people, you have to follow them for a very long period of time, and you have to see if they get diseases less often, if they die less often in the group that gets the drug versus the group that gets the placebo, the sort of sugar pill that doesn't do anything. So it's a really, really challenging thing to do. It's often very expensive because you've got so many participants in that trial. One that we're really hoping will get started soon, and there have been a number of sort of false starts with this, is a trial for a drug called Metphormin. And Metformin is a drug that's actually, some people listening to this might well be taking. It's one of the most commonly prescribed drugs in the world. It's a diabetes medication that helps control your blood sugar. And we've been prescribing it in the UK since the 1950s. So it's really, a drug that we've got a lot of idea about how safe it is, about all these different, aspects of how it works in terms of side effects and stuff. But really interestingly, it might, in addition to its ability to control blood sugar, help with the aging process too. And I think the most compelling evidence for that was actually a study that was done in the UK in 2014, I think. And it was a medical record study. So they were looking back at what people's medical records, people's medical history. And they were looking primarily, the study was to try and determine the difference between metformin and another kind of diabetes drug called a sulfonylurea. Don't worry, there will not be a test at the end of the podcast. So they got a group of people taking the metformin, a group of people taking this other drug. But to be sort of belt and braces secure about the results of this, they also got a control group of people who weren't taking any drug or weren't taking either of these two drugs. And the reason, of course, they weren't taking those drugs is that they didn't have diabetes. Now, what do we know about people who don't have diabetes? They're normally healthier than diabetics. And the reason is that diabetics, they're often overweight, which is can be a contributing factor to the diabetes. The diabetes can then go on to cause various health problems. So it can cause cardiovascular problems, amongst other things. And so it's, you'd expect those people who are non-diabetics to live longer than the diabetics taking metformin. But what they found was, firstly, metformin is indeed better than sulfonylureas, which is why it's considered the first-line therapy for sort of type 2 diabetes, the diabetes you get with older age. But secondly, they found that the people who weren't diabetic and weren't taking metformin actually lived a shorter life than the people who were diabetic and were taking the drug. And so the potential theory here is that maybe the metformin, as well as controlling the diabetes, is having some broader effect on the aging process. Because this really counterintuitive result that people with a disease are living longer than quote unquote healthy people. What's going on there? The challenge is that because this was a backward-looking study looking at people's medical histories rather than looking into the future, there could be other reasons that this effect was seen. And I think a really good example of that is just very obvious, actually. It's the amount of care that you get from the medical system. So imagine you are a diabetic, you're going to be going and checking in with your doctor, every so often.
So other things are caught sooner.
Exactly.
And you're kind of, there's an eye on you at all times,
exactly.
right?
So, say your blood pressure starts going up, your doctor's going to notice it 6 months later, stick you straight on a blood pressure drug. Whereas, a lot of people are walking around with high blood pressure, especially older people. They just don't know. They don't realize they need to be on a drug, and therefore, maybe that's what's going on. It's nothing to do with the metformin. So what we really need is a proper randomized trial where we get a bunch of people. And so there's actually this trial called TAME, which is Targeting Aging with Metformin. It's another one of these tortured science acronyms. And the idea is that they're going to get a bunch of people between, I think, the ages of 60 and 79. They're going to give 3,000 of them, half of them metformin, 1,500, half of them something else, that an inactive pill that looks the same, tastes the same, etc., etc., so they don't know what they're getting. And then they're going to follow them for 3 to 5 years. And the way they're going to check if it slows down aging or not is to see, do the people who get the metformin, do they get cancer later? Do they get heart disease later? Do they get dementia later? Do they die later? And they're going to have this sort of composite of all these different diseases that we know are aging related and see if the metformin can slow down that onset. And because this is a randomized trial, because it's not that, whether you have diabetes or not that determines whether or not you get the drug, it's literally random, that is the nature of randomization, then the only difference between those two groups is going to be the drug. And so whatever else they're doing should be roughly equivalent.
5 years seems like such a short time to look at, what is it, 6,000 people. If they're middle-aged, between the ages of sort of 50 to 55, you might not see that much difference, no?
Yeah, and I think that's so. The idea is they're going to have people between ages of 60 and 80, and the odds of dying.
Okay.
The odds of dying in that area. So the number off the top of my head is that when you're 65, your odds of dying are 1%. So that means you've got a 1 in 100 chance of dying. When you're 80, your odds of dying are about 5%, so 1 in 20 per year. And what that means is if you're watching, a few thousand people of that age bracket, then some of them are going to get cancer, some of them are going to die.
Yeah.
It's probably going to be a minority of the people that you're following in the study, honestly. But that's why you need such big numbers. And so then that's how you determine whether or not the drug works. The sort of longer term plan for this is that hopefully we're going to develop what are called biomarkers of aging, so tests that can ascertain your biological age. And then, rather than having to wait for years and have huge numbers of people to spot tiny numbers of events, we could then measure your biological age before the trial starts. We could give you some drugs for a few months or some other treatment, and then we could measure your biological age at the end. And there are two really big advantages to this. Firstly, the trials are a lot shorter. I guess there are three advantages actually. First, the trials are a lot shorter. Secondly, you're not literally waiting for people to die, so that's a sort of nice bonus, I guess, as well.
A bit more positive.
But the other thing that's really interesting about that is that it means that every single person in the trial contributes data. So in that idea of the Metphormin trial I was just describing, if you stay healthy, then you're not contributing any data to that trial. You're just carrying on being healthy. Who cares?
Yeah.
But if you've got an epigenetic clock or some other biomarker of aging, then literally every person has an age before and an age after. And so that measurement, it just means the statistics are a lot easier and the trials can be not only a lot shorter in time, but also a lot smaller. That means they're going to be a lot cheaper.
You're going to get a lot more data, right?
2 questions. If metformin is slowing down the aging process, would you say that insulin resistance is one of the main drivers of aging then?
It could be. It's really hard to distinguish cause from effect because it certainly seems that becoming insulin resistant is age related. It seems to be driven in part by a process called inflammation. So another of the hallmarks of aging is dysfunction of your immune system. And what inflammation means, so actually it's very important to distinguish between 2 different types of inflammation. There's acute inflammation, and this is the sort of good kind of inflammation in a sense, because when your body gets confronted with a threat, that could be, it could be an infection, it could be a wound, your immune system recognizes the threat, rushes to the site of that wound, heals it, rushes to the site of that infection and clears out the bacteria, clears out the viruses, whatever it is, but then crucially dies away as quickly as it built up. And that means that, that inflammation has gone away. However, as we get older, there's a process called chronic inflammation. And what that means is that your immune system is essentially constantly a little bit paranoid. It's always looking over its shoulder. There's a sort of low-level activation all of the time. That seems to drive a variety of aspects of the aging process. And one of the things it does seem to drive as well is this resistance to insulin. So insulin is the hormone that tells your body to absorb the sugar out of the blood. And if that resistance happens, then your body gets less good at absorbing the sugar out of your blood and your blood sugar stays high. The challenge then is and this is the real, this is why biology and medicine are hard again. These processes are all super interconnected.
This is where the gut microbiome comes back in.
Yeah, so the microbiome could be related to it as well. In fact, one of the things metformin does is it seems to affect your gut microbiome. So maybe the way it's having an effect on aging could be partly mediated by that. The other challenge is that having high blood sugar has a range of effects on the proteins inside the walls of your arteries. So it can affect the collagen. They can get something called glycated or glycosylated, and that can cause age-related changes. Fundamentally, we know that the cells can also change their metabolism in response to this higher blood sugar. So it's all a sort of tangled, complicated mess. And I think this is a really important thing to take away about the aging process in general. Although we've been talking about the hallmarks of aging, and there are sort of these 10 categories of things that change in your body. Actually, I think the better way to think of them, rather than as a list, is that they're some of the key stations on an underground map. And what we really want to do to understand aging isn't to just know what the key stations are. We also need to know what that map looks like. Which hallmarks affect which other hallmarks? How are they connected together? And once we've sort of managed to get that underground map elucidated in a bit more of a clear way, that's when we're going to get the really clever anti-aging interventions. It might be that they don't target any one specific hallmark, but they actually somehow stabilize that network of processes that are happening inside your body. So I think that's sort of the ultimate goal of aging, is to understand that network and intervene in ways that are clever. And what that means is that, when you ask, is X caused by Y? I'm unfortunately going to give you this long, complicated answer because everything's connected to everything else, and it's really hard to know what's the cause and what's the effect, because you can often flip around that story and it's, you can make a good case that it makes just as much sense. So I guess we just have to wait and see.